Hello, my name is Dr. Arthur Vaught, and I am the Director of Labor and Delivery at the Johns Hopkins Hospital. And I'm here to talk to you about both innovative and consolidated care plan for women with maternal cardiac disease. So how is maternal cardiac disease defined? Well, initially and in the past, cardiac disease in pregnancy was more so defined by chronic hypertension or women that had hypertensive disorders of pregnancy like preeclampsia or HELLP syndrome. But more recently, maternal cardiac disease is more specific. It is inclusive of women with aortopathies, women with cardiomyopathy, women with heart failure, women with valvular dysfunction, women with arrhythmias, and also women with congenital heart disease. You may not know this, but during pregnancy, a woman's intravascular volume increases by 60% by the mid-second trimester. As you can see on the chart by the yellow line, which means cardiac output, which is the amount of blood that your heart pumps in a minute, you can see that this increases to about 50% by the mid-second trimester or 20 to 24 weeks. It peaks at the time of labor and at your delivery, and then slowly declines over the next 6 weeks into the next 6 months. Because of these intravascular volume changes or fluid changes, women with maternal cardiac disease are at increased risk of having adverse cardiac events. These can be inclusive of new arrhythmias, worsening arrhythmias, fluid overload requiring hospital admission, and even ICU admission. That's why it's so important for women with maternal cardiac disease or women like you to have a group of physicians that feels comfortable caring for them. And that's why the Johns Hopkins Hospital was charged with creating the Cardio-Obstetrics program. Within our program, we have 2 maternal fetal medicine specialists with dual certification in critical care, including myself. There are also 2 cardiologists that are versed in adult cardiac medicine, and we have a cardiologist that is specialized in adult congenital heart disease. We also have wonderful cardiology and maternal fetal medicine fellows that you will meet, and we're both able to perform both inpatient and outpatient services. But at Hopkins, we're more than just a team. We're an infrastructure. Within our maternal infrastructure, we have obstetric anesthesiologist, cardiac anesthesiologist, availability of cardiac surgeons and vascular surgeons, as well as access to our subspecialty clinics like the connective tissue disorder clinic. For fetal care, we have a fetal center that is both innovative in new echocardiographic techniques as well as sonographic techniques. We provide first trimester screening as well as preeclampsia screening, and we have a level 4 NICU if your neonate should need it. What are the levels of maternal care that we provide? Well, that depends on the type of maternal cardiac disease that the patient has. We can do anything from outpatient consultative services to inpatient care and delivery services that require both us to be there at the time of your delivery and labor, or require us to be a part of your coordination of care. One of the first questions that we get in our consultative and inpatient practices, can Hopkins take care of me? Can labor and delivery take care of me? And the answer is yes. As you can see here, we have a cardiac monitor within our labor and delivery room equipped to do 24-hour telemetry as well as invasive monitoring if you should need it. We also have a neonatal bed that is for your neonate after delivery so that you can continue to bond with your neonate on labor and delivery. One of the second questions that we get is, I have a maternal cardiac lesion, am I going to have a C-section? And the answer at Hopkins is no. Actually, when we looked at our own data of greater than 14,000 deliveries, 200 of which had maternal cardiac disease, we actually did not find that women with maternal cardiac disease alone had an increased risk of cesarean section within our population. Meaning that many women with maternal cardiac disease at Hopkins are offered a trial of labor and their C-section risk is not that above our population. Who else do we see in our clinic? So we see women with severe intractable hypertension or on greater than 2 antihypertensive medications. We see women with chronic kidney disease, women with complement and autoimmune disorders, hematologic disorders, women with a history of early preterm preeclampsia, women with lipid disorders, and even women with a history of myocardial infarction. So how do you get referred to our clinics? It's easy. Either you or your primary OBGYN can call us at 410-502-3200, and we'd be happy to see you. Thank you.